Welcome to today's Live with Leadership session. We urge all participants to ask their questions through this session by using the Q&A chat function at the bottom of your screen. If you have any technical related issues, we ask that you put those in the chat box and someone will try to assist your needs. Again, my name is Harold Phillips, and I'm with the Office of Infectious Disease and HIV/AIDS Policy in the Office of the Assistant Secretary for HHS, Health and Human Services. And welcome to today's Live with Leadership session. I'm really excited, several reasons. One, this is our first Live with Leadership conversation of 2021. So Happy New Year, everyone. And this is one of many conversations that we hope to have throughout the year that are part of our overall effort as we work to end the HIV epidemic in the United States. Today, we have Dr. Harold Dieffenbach with us to discuss new research and updates that have been recently shared at the HIV Prevention Conference known as HIV Research for Prevention. And so, Dr. Dieffenbach is the director of the Division of AIDS at the National Institutes of Health, where he oversees a research portfolio of more than $1 billion. And I'd like to turn it over to Dr. Dieffenbach to introduce himself and to touch on a few highlights for the conference. But before I do that, I want to thank Dr. Dieffenbach and his colleagues at NIH for all of the great work that they're doing around COVID-19 and the vaccine work and the research. They really have been unsung heroes in the background, doing amazing work that someday soon will get us all out of our houses. So Dr. Dieffenbach, tell us a little bit about your work and about the conference.
It's really a pleasure to join you today, Harold, and to participate in the first of these events in 2021. Today is the last day of the conference. It's a virtual conference. This is a conference that is held every other year. It was to have been in Cape Town, South Africa. It was originally scheduled for the fall. We moved it to now and decided to go remote. And so it has been a good 4 days of discussion about what's new in HIV prevention, both domestically here for the United States as well as globally. And I think that one of the great things about the HIV Research for Prevention meeting is its global reach. So in that sense, it has a profound impact, not just here, but abroad. So there were a number of major themes that emerged from the meeting. And it all ultimately could be boiled down to how can we improve the choices that people who want to seek means of protecting themselves from acquiring HIV, what are their options? How can we improve the method mix, the choices available? There was a lot of work done and presented with new findings in different areas of pre-exposure prophylaxis, monoclonal antibodies, improvements in treatment as prevention. So as an overall theme, we could say it was about choice.
Wow, that sounds amazing, because we have noted that from a consumer perspective, as well as the healthcare workforce, that we need more choice and options. You mentioned that this is an international conference, and we know that some countries like France, they have adopted sort of the 2-1-1 model for PrEP, 2 days, 1 pill, I think how that goes a little bit. Can you talk a little bit about that? And was that shared at the conference? And are we seeing any progress in that direction?
So PrEP is the sort of the standard tenofovir diproxyl fumarate plus FTC is the standard basic PrEP. And so the great thing about PrEP is it is incredibly effective. But as you were alluding to, it requires this adherence level. And that's why the Europeans have an episodic approach. We tend to take a more take a daily approach. But one of the areas that we've really worked hard on is how can you try to remove some of the behavioral aspects from PrEP? One of the things that came out at this conference was a full report on two big studies. It's called HPTN 083 and the other HPTN 084, which looked at an injectable form of PrEP, where this was injected every 8 weeks for a period of time and then compared in a blinded way to tenofovir FTC. So everybody had an active here. They all were either injected or they got oral PrEP. In both men and women, the injectable was superior to tenofovir. It's significantly superior. And this is important because at the end of the day, what we need are things that really work. Now, there's some really beautiful little stories within this, but suffice it to say that we are moving forward now toward filing licensure applications for injectable PrEP. And that is going to be a significant amount of work over the next 6 to 9 months to a year.
Wow, thank you for that. That's really exciting that there will be additional choices when it comes to PrEP, and that the researchers are really looking at ways to make this easy for individuals. And you talked about some of the behavioral pieces, the pieces of having to remember to take a pill every day or remembering to take your pill. So let me ask you my second question around how does NIH work with its federal partners and other implementing partners to ensure that the latest research, like the excitement around the injectables, gets out into the community?
So it's really important to realize that this is a multifaceted relationship. NIH supports the research, but the research is not done in a vacuum. It's done in communities. And it's done with researchers at institutions, both domestically and overseas. And the community is so critical for this, because without community buy-in, without community interest, nothing gets done. We need people who provide the study product. So that's a company issue. And how can we do this? But ultimately, we need to take these to scale. And how do we do that then? And it starts very early in the process where you start talking to implementing partners. For example, when we're working internationally, PEPFAR really tends to be a significant implementing partner. Same with Clinton Health Initiative is a major partner. Domestically, our partnerships are with HRSA and CDC. Dawn Smith at CDC has been one of the major leads in the implementation of PrEP over, can you believe it's been 9 years since PrEP was approved? It'll be 9 years in July. So this is tried and true. We still are struggling with PrEP implementation, frankly, as a country, as you're aware. But just to come back to this issue of choice for just a minute, one of the other areas we heard about at this meeting was a pill that would last 30 days. So we have this idea of, so some people don't want an injection. Some people don't want to take a daily pill. Would they take a pill that is every 30 days? So this is just an example of how we're expanding these options out. I think that the challenge we face with the implementation still gets around the pharmacy issue. How do we get a prescription from the doctor? And so many people who need pre-exposure prophylaxis either can't afford it or their health insurance has such an extraordinary copay. So I think going forward, we really have to make sure that we take the department's own Ready, Set, Prep program, continue to evolve it so it truly can engage the people most in need, pay their medical bills or make it truly free. I think will be a big thing as we go forward.
Great, thank you for that. If those of you in the audience, if you have questions, we encourage you to put them in the chat box and we'll get to as many questions as we can. I myself have two other quick questions for Dr. Dieffenbach. When I talked, I opened up and thank you and the others at NIH who've been really involved in COVID-19 and some of the research. It's affected, as we know and we've talked about on the in some of our federal meetings, it's affected both care, HIV care and HIV prevention, and it's also had an impact on research. You've talked a little bit about that, and Dr. Goodnow has told me some of those impacts. But for our audience, what do you see as the biggest impact on research into HIV prevention and care as a result of COVID-19?
Well, I think we have to step back and realize that starting in March, many universities closed their research facilities, closed their hospitals, shut down many of our clinics where we were seeing our study participants and doing what we needed to do. We quickly pivoted and prioritized our studies to what we could do that was remote to keep the studies going. And at that point in time, we had some very high value trials that were in very particular points in their process that if they had gone south, if they'd blown up, it would have been a major, major problem. So we prioritized where we would focus, put time, energy, and resources to those. But at the same time, started with programs to encourage ways of opening up. And one of the things we worked to do was engage many of our clinical groups in COVID testing. Can they help their universities by reopening, get involved in COVID testing? We were able to work with HHS leadership to have funding to provide them for that kind of testing, and also then provided them the personal protective equipment that they couldn't get. So by allowing our sites to open up a little bit and get used to working in a COVID environment and testing with COVID, they were then able over time to re-engage and reinitiate many of the HIV trials that had been suspended. At the same time, the universities then saw the value of what our sites were providing to the care and treatment of people who were coming in with coronavirus disease. And yes, many of the HIV researchers are infectious disease docs, and we're really burning the candle at both ends. But everybody stepped up and contributed. And I would say the impact has been uneven across the board. Some programs were significantly impacted, others less so. But the NIH is busy working up potential remediation for grantees that lost a year. I mean, you think about a new investigator just getting started in their career, you lose an entire year out of a grant. What are you going to do? So that's the challenge. I could go into specifics, but I think that pretty much captures it.
No, that's great. I think it's a great example. We've talked a lot about, I think over this last year, sort of the resilience of those on the front lines with HIV prevention and care and treatment and how they've had to modify and adjust. But it's also good to hear that sort of same characteristic, the same characteristics of commitment and resilience also exist among our HIV research communities as they've sort of had to make that shift and adjustment. So I'm going to go to one of the questions in the chat, which is about the recent study from New York State that shows that people with HIV had poorer health outcomes due to COVID. I think this article was in JAMA. It talked about higher rates of severe COVID disease requiring hospitalization. And it's got some in the community very concerned about the need to ensure people with HIV get vaccinated, and if the approved vaccines and those in the pipeline are all equally efficacious and safe for people with HIV. What would you say to the community that has some of these concerns as a result of that article, Dr. Dieffenbach?
So I think that article is an important article to look at because it clearly compared people living with HIV to a group of people who were not living with HIV. And there was no difference in rate of acquisition. So living with HIV did not cause you to be more susceptible. but the disease was worse. And we have to then ask the question, why? And if you look at what we know about the population, particularly people living with HIV over 50, is they have a significantly higher rate of comorbidities, diabetes, cardiovascular disease, tending to be a little bit on the heavy side. All of these factors that by themselves cause people who are not living with HIV to have severe outcomes. To me, HIV is what we would refer to as an epimarker for a population that is impacted by the comorbidities. So it's not the HIV that's causing the problem per se, it's the comorbidities that they're associated with. That said, most jurisdictions, as they think about prioritizing people, would prioritize people with comorbidities into higher categories or sooner categories for vaccination. I think that's where the people living with HIV fit. HIV per se, not so much, because as we looked and did in the vaccine studies, people who were suppressed are not immunocompromised. They can participate in the vaccine studies and did, and were included as normal, healthy volunteers, because we wanted normal, healthy volunteers, also people with comorbidities. So let's focus on not the HIV part, but the comorbidities. Let's not use this as a way of stigmatizing people with HIV. Let's make sure that people get the care they need based on the diseases or the conditions they have.
Thank you very much for clearing that up. I know that there's been so much information and sometimes it is confusing. So it's really great to have you here and give us the straight story. So another question that has come into the chat is, you mentioned injectable PrEP and you mentioned seeking licensure for PrEP. The question is that something NIH does, or does a partner apply for licensure for PrEP?
So that's again, it's the partnership. We have all these people together, working together. We have the grantees, we have the NIH, and we have the company. We were the sponsor of the PrEP trials, so we have a role in the filing, but ultimately it is the company that will take the ball and run with it in the future. But I would say the partnership with ViiV has been fantastic, and they're a pleasure to work with.
Great. So here's a question that I absolutely love. You've mentioned the monoclonal antibodies, injectable PrEP, the potential for a monthly pill to prevent HIV. Are any of these likely to become widely available in the next 5 years? And if so, what can healthcare providers, researchers, advocates, and others start doing now to pave the way for awareness and uptake of these new options?
I think within the next 5 years, we will have the injectable cabotegravir will be licensed. There's a high probability that there will be the 30-day pill and other formulations of that company's product, maybe 7 days, maybe others. Additionally, there may be additional injectables that are available as well. Antibodies could be potentially licensed. I think it is important that we have the opportunity to talk to communities about what is coming and engage them in the discussion about choice, that these are going to be options and opportunities for you. Here's another example of a choice that may be right around the corner. Can we co-formulate contraception with oral PrEP? So if you think about women who want to protect themselves from HIV and also want to protect themselves from pregnancy, could this be co-formulated or co-packaged into a single pill? Similarly, if people didn't want to take a pill but wanted to use, say, a vaginal ring, can we have a co-formulated ring that delivered contraception as well as anti-HIV meds that would protect women from acquiring HIV vaginally. So those are the kinds of other products that are in development. They're not new. A lot of this is moving along, but all these choices will come to the fore, and we will need to have programs such as HIV.gov, where all this information is available to the community, so that we can provide them the facts. But oftentimes the website itself is not enough. So we're going to, I think one of the things that we're going to need to struggle with over the next 4 years, Harold, is how do we adapt our messaging to the influencers, to the need for the Instagrams, the need for these other platforms that, frankly, somebody as old as I am has no business being on, but we need those influencers. We need to engage youth to come in and help us make sure that we're getting the messages right, but then also to provide the information. Because really what we want is uptake by the young and the most vulnerable. But in that case, then it's going to require us doing things differently than we currently are.
I think our office would love to help you with that. One of the things that I have learned is that the HIV researchers are really looking at some of the problems and challenges that we have on the front line, and really are looking at how to create solutions to those problems. You talked about both safety, efficiency, convenience, I think both on sort of the healthcare workforce side, as well as sort of the end user. The idea of contraception and PrEP sort of combined. I'm just thinking of like what that would mean for some of our populations. So maybe pulling the community back in to have the conversation about, now we've solved some of these problems, how do we get the message out and how do we deliver them? This is great. I've got a couple questions that maybe I can get to before they cut me off. One is about has the development of the mRNA vaccine for COVID lent anything to the potential development of an HIV vaccine? And another question was about whether or not at the conference there's been any developments about or moving toward a vaccine. But I know this was mainly a prevention conference. So
well, clearly HIV vaccines were a big part of this conference too. It just didn't have the headlines that we had for these other breakthroughs. You know, there are still 2 efficacy trials in HIV vaccines that are currently ongoing. And one is in the Americas and one is in South Africa. These 2 studies are from one of the companies that we know very well, Janssen and J&J. It's using the same delivery system that J&J used for their coronavirus vaccine. So it is an incredibly wonderful, powerful, safe system. And those studies are ongoing. So, you know, would it be that we had got an answer? We didn't. The studies are ongoing, but that's all good. But what we are seeing is that many of the platforms, like the J&J platform, were specifically developed. In the case of the J&J, it's for Ebola, HIV, and now coronavirus. For the mRNA vaccine by Moderna, we were working with them already on mRNA vaccines for other diseases, including HIV. So it all just comes together. And this is the partnerships that you have with long-term relationships with these kinds of companies, where you can pivot overnight. The group at the VRC designs the immunogen, types the sequence in, and within a matter of days, we are testing the Moderna vaccine at the VRC, at the NIH. And that's a testament to the leadership of John Mascola, Barney Graham, and the whole team, and Dr. Fauci.
Thank you. I know among some of my family members, they were questioning, how is it that this vaccine happened so quickly? And I had heard Dr. Fauci talk about how some of the research for the coronavirus vaccine lended or borrowed some of the expertise from HIV. And so that had us a little bit ahead of the game. Also, some of the previous infections, diseases, bird flu, all the rest of them, we built this sort of bulk of knowledge and expertise that really did help us. It helped calm my family down a little bit because they were a little nervous about sort of the speed that this all happened, but that it's real. But so our last question is along those same lines, Dr. Dieffenbach. What would you say to people with HIV who are hesitant to get the COVID-19 vaccine?
Oh, I don't think there's any one specific overarching reason people are hesitant. And I find there's not some magic words you can say to people to deal with vaccine hesitancy. It is really about a conversation to unpack what they're feeling, what they've heard, and what you can tell them that you are confident in the facts, and then allow them to process this, to understand that this is in their best interest. I really think that taking it seriously and acknowledging that vaccine hesitancy is real and needs this conversation between people who understand exactly how these things work from the time it enters your skin and gets in your cells, and how it doesn't rearrange your DNA. It can't make you sterile. It can't shorten your life. The stuff goes in, it does its business, and suddenly it disappears out of your body because the body destroys RNAs all the time. And it's about really finding out what it is they've heard that makes them concerned. So I think it's not a 20-word statement. It's really about taking time to talk to people.
Talk to people, but get the shot is recommended, right?
Talk to them while they're in line to get the shot.
Dr. Dieffenbach, thank you so much. This has been a really informative session, and thank you to all of our HIV researchers that are out there really and truly sort of solving some of these problems that who could have imagined 10 years ago that we would sort of be at this place where we're talking about injectables and a 30-day pill and combinations of contraception and HIV prevention. It truly is amazing. So thank you very much. And thank you at the team at NIH and our HIV researchers around the world. For those of you who are interested in learning more and wanting to see future Live with Leadership events, please join us at hiv.gov. Please sign up on hiv.gov for more information. Dr. Dieffenbach, any closing words as we leave you?
No, I just want to thank you, Harold. I want to thank the department and hiv.gov for sponsoring this. I think it's very important. Moving forward, we look forward to a day when we have beaten HIV and coronavirus, and then we'll be on to other diseases, because there will be more.
Absolutely.
Thank you.
Thank you so much. Bye, everyone.